on this, unlocking the full potential of drug chart beyond routine usage. So we will actually go through what is the routine usage, but look at the nuances of how we can avoid medication errors. So that is the purpose of this webinar. I would start with the question, why do you need a drug chart? And then what is the purpose? What to fill and how to fill in the drug chart? And what are the types of the sections in the drug chart that we have? Okay. So if you look at the traditional way in which medicines were given out to patients, doctor will write in the progress notes or doctor's orders, and then the nurses will administer the medication. So this is how it was done when I was in medical school. And when I started house agency, I came to the ward, there were about 60, 70 patients, and my postgraduate came and dumped all the case sheets on my table and said, you have to write the orders for all the 60, 70. I was thinking, how was that I'm going to finish this job? And then, he looked at my face and said, smiled and said, no problem. You just write GC fair, repeat all for all the patients. And this is for the last 5 days. So, that's how we were initiated into writing prescriptions, but times have changed a lot. So, but that time it was very simple. Just write the orders in the doctor's orders or the progress notes. The nurses kept track of the medications and they used to give them. And based on that, we would follow the orders. So because of that, a lot of problems happened. There were duplication of drugs. Certain drugs were missed, and some drugs were not stopped. They were continued, because there was no proper documentation. And importantly, there was no way to check whether the drugs have been given or not. So that is the main problem with this sort of method. So there is no doubt that we need a uniform location to manage medication, where the doctors will write the prescription and nurses will use the same thing as the doctor's written, and that is known as the drug chart. So this is what has happened. So with the advent of quality and NABH coming in, all of us have sort of moved away from writing in drug chart, the progress notes and the doctor's orders, and writing in the drug chart. But it has been a challenge to basically change the doctor's habit to write in the progress notes or the doctor's orders. So a partial usage is done in some hospitals. So where the doctors still continue to write in the progress notes in doctor's orders, then the nurses will transcribe that in the drug chart and then administer the medication. This also leads to errors, mainly transcription errors. And because of this, wrong drugs can be given, dosage errors happen, and many other errors happen. So partial usage is better, but still it is not 100% accurate. So you need a full implementation where doctors write the prescription in the drug chart and the nurses administer the medication using the drug chart. So that is a full implementation which needs to be done. And the whole process has to be also have a quality control. Usually the senior nurses will do this, but now we have a separate segment of professionals called the clinical pharmacists who help us in do the quality control of this drug chart and thereby reducing medication errors. So what is a drug chart? Drug chart is a comprehensive document used to record and manage a patient's medication regimen. It's very simple. So basically, it will tell you what medicines are prescribed, what are the doses, routes of administration, how frequently the medicines have to be given, and any special instructions. So that's basic, all the information. Why we need a uniform process is not only the prescription is there, but also whether it was administered is also in the same chart. So that is the main purpose of the drug chart. So the other names, we call it a medication chart or medication administration record, MAR, prescription chart, drug cardex. Several names are given in different hospitals, but when I say drug chart, I mean all these names. So the purpose or several purposes are fulfilled by using a drug chart. One is, as I told you, increase patient safety. There is medication error reduction. And because you keep writing about the allergy, those alerts are also available. The second is accurate medication management, consistency. So if you have the, in one uniform location to write, then everybody is tuned to writing this, and therefore there is a standardized practice, and very quickly you can verify. So the verification accuracy also goes up, and the time taken to verify is also comes down. Then there is enhanced communication because there is single location, interdisciplinary coordination is better, and while handing over also, you can use the drug chart to hand over. Legal and regulatory compliance because of the documentation, and you can always have an audit trail. Patient and monitoring and evaluation is much better, and patient education also can be done using the drug chart. So these are all the purposes of using a drug chart. Now, what to fill in a drug chart? I will handle this under 3 sections. One is what are the patient details you have to enter. Next is the medication or drug details. And the third is validation. Validation meaning has it been given and has it been checked for quality. So these are the 3 things which has to be done with a drug chart. So let's first start with the patient details. So the patient details, as you can see here, this is just a part of the drug chart, which will be on the top, where you need to write the allergy history here, or sensitivity, which ward the patient is in, the weight, if it, because it's for dosage dependent drugs, you need that, and the date, the hospital number, the name and address of the patient, or usually we stick a label now, and the patient's age and sex and the consultant in charge doctor's name. So this is the patient details which should be there in every drug chart. Now, allergy history, you should write both positive and negative, and also write drug sensitives. So if there is drug allergy, you don't know, or the patient says, I am not aware of any, then you will say there is not known allergies as of present. So this is one of the drug charts which we use, where there is instruction to the doctors and nurses. We will get into that in detail in the subsequent slides. Now, the drug details is much more information than the patient details, so we will take a little bit of time in that. The prescription or the drug details, when the doctor writes, starts with the date. You have to write the date at which the drug was first prescribed, as you can see in this example. So in this date, all these drugs are prescribed, and this is the next date. Now, when the morning rounds, the doctor writes the orders. So that's the start date. And when you write the drug names, you have to write the approved drug names legibly and correctly spelled. Don't use small letters, always use capital letters, and do not use abbreviations, unapproved abbreviations. We'll talk about abbreviations more in the next few slides. Now, there are certain things which are very basic. Don't use T instead of for tablets, because that can be mistaken for I. People may take it as injection. So similarly for injection, no, as you can see here, don't give this abbreviation INJ. It should be injection in full form. Okay, so all these are prone to be misunderstood. That's the reason we said avoid these abbreviations. Now, here is an example of drug dosage error. This doctor has written for Lantus 8 units. You can see here. So that U looks like a 0, and the nurse actually mistook it for 80 units and gave this patient this dose, and the patient developed hypoglycemia and has to be revived urgently. So this is one example of why you have to be very careful in writing the drug orders. Now, there are certain best practices for entering drugs whenever you write the dosages. So you never have any trailing zeros. For example, if you write 5 milligrams, you don't put a decimal and 0 like this. So because that will be mistaken as 50. So no trailing zeros is one thing. And when you write quantities of 1 gram or more, then you can write like that. 1 G is what you have to write. So again, GM can be confused. Don't write like this. Okay, so it is 1.5. So anything over 1 gram, you can write in decimal form, 1.5 like that. But for quantities less than 1 gram, use milligram. Do not use 0.5 grams, because again, If you do miss the 0, it will be taken as 5 grams. So don't use grams. When it's below 1 gram, you use milligrams. 500, 750, 250. That's the nomenclature which you have to use. And write quantities less than 1 milligram as micrograms. Don't write it as 0.1. It's the same logic because these can be mistaken as 1 milligram. If decimals are unavoidable, then always put a number in front of the decimal point. If there is no number, you have to put 0. But if it is 1.5, 2.5, you have to put that number. Okay. So the another very important point about doses is you should not abbreviate the words micrograms, nanograms, and unit. And the word unit should be written in full. It should not be abbreviated to U or IU. You can abbreviate the milliliter into ml. In fact, M should be small and L should be capital. So that really, avoids the errors. So here is, what is known as forcing function. So you make, when you print the drug chart itself, you make sure that this is printed there and the doctor can just circle that. So this avoids errors also. So this is known as, one type of human factors engineering where you force a function to avoid errors. So here are some mistakes in abbreviation. So same thing, 4 units is mistaken for 44 units of insulin. And here there is no QID. It looks like QID or QD, we don't know. Because QD means it is taken once a day. QID means it is 4 times a day. So you have to be very careful while using these abbreviations, right? And similarly here, this doctor's handwriting is, very typical of doctors, that's a standard joke. So it's a drug called Plindil, 5 milligrams, but this L and the 5 has joined together and looks like 15 milligrams. So this is how, abbreviations or just not taking care of writing the prescription properly can lead to errors. Now here is the Institute for Safe Medication Practice, ISMP, guideline for avoiding dangerous abbreviations. So these are all the dangerous abbreviations here on the left side you can see. I'm just going to take a few examples and they give the logic of why this, so by the misinterpretation, what is the correction. So if you write microgram like mu and g, it can be mistaken as milligram. Okay, so the huge difference, isn't it? So always use this as mcg, not as mu and g. Okay, when you write microgram, it should be mcg, and when you write milligram, it should be mg, and when you write grams, it should be g. Okay, so like that, there's several. I'm going to take up this injection, ij or inj, mistaken as iv or intrajugular. Therefore, use injection like that. Okay, and most important is iu, international unit, mistaken as iv or 10. Okay, always use daily. And we write this OD quite a lot. Once daily, that may be mistaken as right eye because ophthalmologists use this. OD means oculus dexter. OL means, what is the opposite of dexter? I think it's AU, was it? AS. Any of these things is not to be recommended. So I hope I made the point. So you can download this. It's a huge document listing all the dangerous abbreviations. You can implement whatever is required in your hospital. So now best practices for entering frequency. So specify the dose and the frequency. So you can either write it as Q8 usually parenteral medications, you should always indicate the hours frequency. Whereas for tablets, you can write either 111 or these, TDS like that. So 111 is much clearer than TDS. Okay, so I given both these examples to see what difference it makes. Okay, so parental always write the hourly because more accurate dosing has to be given. And for tablets, you write this 111, that sort of methodology. Okay, so when you write as required prescription, it is always better to include the indication for writing as required medication. Now here are some examples, how you can design your drug chart. So if this is a regular prescription where you write the drug name, the route, the dose, the frequency, start time and date, and prescriber signature and registration number. And then the nurses will fill in here the date and time, the dose and the route and who it was given by. So this is for regular medications. And whenever this particular medicine has to be cancelled, they can put a tick and a line across to show that this has been cancelled. So this is once only medication. So you may sometimes have, the patient may have vomiting and you just want to give injection Emicid. So here you have to write the date, time of drug name, route, dose, and then you prescribe. So that will be given by the nurse and the given time is recorded here. So this is once only medication. And as required, otherwise known as PRN medication. So here you write the name, route, all these things is the same as regular medication, but you have to tell the frequency, the maximum frequency of a PRN medication. So you don't want them to use it more frequently than that. So that is very important to enter here. And then the nurse will write what time it was given. So that's about the drug details. And then we'll get into the validation details. So the validation is the doctor's validation, the time and signature of the doctor of the prescription. Only that tells that this particular drug can be given by the nurse. Okay, then the time and signature of the nurse in charge after administering the drug, that shows that this drug has been given and what time it has been given. Okay, so this is the time that that drug had to be given, and this is the time the drug was given. So that's very important for auditing these drug charts. So that brings us into the quality control. So basically, you need to sign the prescription in ink, and the drug chart should be cross-checked and signed by the nurse in charge and also by the clinical pharmacist. So there will be one thing in the bottom of each page where it is cross-checked by whom, and either the nurse or the clinical pharmacist. So when you discontinue these drugs or change the orders, there is a certain way to do it. So you need to cross off the and administering sections of the drug chart and sign and write the date on the chart. Okay. So you just have to, just cross it out. So don't sort of strike it out. So the rest of the days you cross off and write DC, that means discontinued, and your signature, date and time. So this will make sure that this drug is not given. If you want, you can cross out right from here. But as long as what this drug is able to be seen. Very important that the record will contain information on what drugs has been given even in the past. So that's the reason we say, don't make too much of rubbing on these drugs. So it could be just a straight line continued like that, or a line after the last dose. So to make sure that drug is not given. And when you change the order change is the same thing here. For example, see, injection pan has been changed to tablet pan. So here again it is struck off, and then it will be order changed, and then the signature, date and time, and then a new order for the tablet should be written below that. So this order has been changed, injection has been changed to tablet. So that's how the drug discontinuation and change of order should be documented. Controlled drugs, narcotics, radioactive drugs and all that, very important to have in triplicate, and write the patient's name. Everything should be written in caps and it has to be entered by the doctor. Okay, so here the patient name, all the details, then the diagnosis, what is the name of the drug, what is the dosage, how much of quantity was prescribed, and what is the frequency, doctor's name, registration number, qualification, signature, and what time it is ordered, and acknowledge of the nurse in charge. Okay, so this order is valid for 1 hour. Okay, so and the request number is also raised from the pharmacy. So the whole thing is very much controlled. So because of the misuse potential for these drugs. So IV orders, again, you have to write the name of the drugs and the infusion. So let me show that in here, it's much clearer. So this is infusion therapy. For IV infusion and blood transfusion, you write the date, what is the fluid you want to write, normal saline, renal lactate or blood, what is the volume, what is the rate, what is the infusion route. Okay, so that is the infusion. If you are adding any drugs, no, then you can write those additives here. And then this is for the nurses, who to set up by, and what is the infusion batch number, what is the additive batch number, and what was checked by another nurse. So that is for the infusion therapy. And there are certain best practices. Insulin and warfarin must be prescribed on drug charts with the instruction to see the insulin prescription or see the anticoagulant prescription. It should always be cross-checked, and doses must not appear on two separate charts. Never use two drug charts at the same time. Okay. If you have to use the two drug charts, you have to name them 1 by 2 or 2 by 2. If the number of medicines is more than that can be written in one drug chart. That is the only excuse for using two drug chart. If no, there are so many drugs that one drug chart is not enough, then you can take the two. Second one, you write, 1 out of 1, 2, 1 out of 2, 2 out of 2, and then you have to, sorry, 1 out of, if there are two charts, you write 1 out of 2 and 2 out of 2, and then you clip them together or tie them together. Very, very important. So insulin, here is a good example of an insulin thing where it is clearly mentioned for breakfast, lunch. I think there is one for evening and bedtime. It's a separate insulin chart, and you can track the whole thing. What is the type of insulin, and whether it is given evening, what time it is given, and if there are two drugs to be given, there is a provision to enter these two drugs also. And there is, you see, the nurse's initial is 2. This is because insulin has to be cross-checked either by another person, either the nurse or the patient themselves, if they are, regularly using insulin. So that is the way insulin chart works. And you can also include, that's why this name of this presentation was outside routine use. So I want to give some uses where we don't routinely use it. So here is for an oxygen prescription. Usually oxygen prescription is again written in the doctor's orders, and the loop is not closed. The nurses will implement it, but it was done, what day, time it was stopped, and all that, we have to ask the nurse. It is not documented. So that is, here is an example of oxygen prescription. So where you mention what is the saturation goal you want to achieve. Is it continuous or PRN? What is the maximum percentage? If you're using Venturi or any other devices, what is the FiO2 you want to use? And what is the flow rate you have to set for that particular FiO2? And then you put the date, time, signature. And here the patient's name is there, and the nurses will keep monitoring the device they've used, what is the saturation, what is the oxygen percentage, what flow rate they have been used. And this gives a very nice representation of the oxygen therapy, and it could be part of your, because it is another prescription, isn't it? So it could be part of your drug chart. So it's all up to how much you want to bring in quality in every aspect of care you give to your patients. The other thing I wanted to emphasize is antimicrobial prescription. So the antimicrobial prescription, usually we write it as part of the drug chart. But certain hospitals, for this example, I've taken a prescription from a hospital in NHS, where this chart is a part of antibiotic steward policy. Okay, I'll explain why it is. So you can hear is the initial prescription. Initial prescription, you have to write the dose, route, and frequency, and you write whether your diagnosis. Say, for example, pneumonia or enteric fever, and write whether it is a probable diagnosis or possible diagnosis. What is the difference? Probable is infection is the most likely diagnosis. Review the diagnosis and antimicrobials daily. Possible means infection is not the most likely diagnosis, but antimicrobials are being used as a precaution. Okay, so sometimes you do that empiric, right? So when we start as empiric antibiotics, this is how you first give the information, and then you put the start date, time prescribed, and you can note here the prescription is only for 2 days. By the time you should have made the decision either by using a culture and sensitivity or by clinical decision making, and it will stop. Okay, if you has to be continued beyond 72 hours, then a senior person has to review and tick here whether to stop continue. If you're continuing, whether the IV has to be changed to oral or switch to a different antibiotic or no change. Okay, so this will be signed by the senior, and also the clinical microbiologist or the will be signing this. So this is the antibiotic stewardship, which will prevent antibiotic misuse. And here is clear instruction about if the patient is allergic to penicillin, what all drugs they should avoid giving. So this errors also will not happen. Okay, you can see penicillin allergy is printed in red, and the similar information is printed in red also. So this is for initiation. So once you initiate, and suppose at the end of 2 days there is no indication for antibiotic, it will be stopped. If it will be continued, then it will be continued in the finalized prescription. Okay, so in the finalized prescription, you have to write this, antimicrobial name, dose, route, frequency, diagnosis. Now you know the diagnosis, intended duration for the treatment, and then you sign, and the pharmacy will to cross check. Microbiology is also recommended. Then you put I here, yes here, and then this will continue. Now you are taken for the third 1, 2, 3 days. It will continue for the 4th day, 5th day. After 5th day again, you need to sign if you have to continue, and you have to write a justification for that. Continues for another 2 days, then you review again, and then another 3 days, you have to refer to microbiology if you want to continue the antibiotics. So you can see how tightly the antibiotic prescription is controlled. So this is something which you can actually use. It is, you cannot combine the normal drug chart with antibiotic prescription. You've got to say, here is a separate antibiotic prescription, which is you have to then add to the drug chart and use it. So this is how it works. You can see here, this is the initial antibiotic prescription chart where you initiate the therapy, and after 24 to 72 hours, you then continue in the continuation. So you may have 1 or 2 antibiotics, so that's why there is more, and this will sort of stop at 3 and then continue at 4, 5. Okay, so that is what I wanted to add to the usual drug chart. So that brings us to the end of this webinar on using drug chart. So we covered the overview about what is a drug chart, why it should be used. So basically, it's a record of the patient's medication, and it has to be written in a uniform location. And then the purpose to ensure safety, reduce errors, enhance communication, ensuring legal and statutory compliance, and enabling patient monitoring and evaluation. The components, as I told, patient details, drug-specific details, validation details. These 3 things should be there in every drug chart. And then we looked at the various areas in the drug chart, like regular prescription once only, as required, infusion therapy, insulin. Then we talked about certain extra uses where you can include that in the drug chart, that is the oxygen prescription and antimicrobial prescription. So that brings us to the end of this webinar. Thank you so much for your attention.